It's very.
Well, I was telling my mom after our class this morning that I felt that was kind of wearing on me, and I don't know how it really was for you. But I told my mom afterwards, I said, the reason that class goes as well as it does is because of the students. So I appreciate what you guys do.
Well, we appreciate you.
Well, you're involved and you interact. And even this morning when I kept feeling so rushed and people were making comments, and I still thought the reason the class goes as well as it does is because of you guys. So let's get moving into this. So
and when I get back I got my answer. I know what killed him. And my husband is right.
Becky, I think I just muted you even though I didn't mean to. Trying to figure out where all the background noise was coming from, so I muted you. But I don't think I'm meant to.
Yeah, it wasn't me. My house is quiet finally.
So today in lab, and like I said, when I've gone through what you need to know about today's lab, I'm going to jump back into lecture. But this lab is about blood vessel identification. So learning the blood vessels. And one thing that they hit on again, and that this lab exercise, or at least the questions that were assigned to the lab exercise, talk more about the capillary exchange pressures. And since that is probably the most complicated part of blood vessel physiology, and also it has to do with heart physiology, I don't think it's so bad to look it over again. And so the very end of this, we'll talk about that capillary blood exchange again. But initially what it is an overview of the blood vessel anatomy. And we talked about the structure last week. This week, we're talking about identifying individual blood vessels. Oh, and look, bear with me. I'm sorry. I'm going to skip back to the syllabus really quick. If you look at the syllabus, your second lab quest is opening today. And it actually, I had it so it's, I think I had it set up so it actually opened at noon. And it will cover, bear with me, I'm coming into the syllabus. So the second lab quest is going to cover last week's lab exercise and this week's lab exercise. It also, your first case study was supposed to open today. It will open tomorrow morning. And so it's going to be similar to the case studies that we went over with, hopefully you think that the questions are easier. Those were more harder because it was material we were still going over in lab and lecture.
Excuse me.
Go ahead.
So I'm a bit confused. I know me and you talked last Friday after class about assignments I thought I missed, but I really didn't, besides the 2 that you told me. And I didn't know, because I missed the one Friday's class, that you had actually emailed information for us. So I didn't complete those. I just seen them this morning.
Just submit them when they're ready, Casey.
Okay. I was like real off. Sorry.
They don't, I'll tell you, those case studies, they don't close.
Oh, okay, good. Okay.
I'm not, if you go in, you'll see that you can still submit them at any time. I don't close those folders. Just submit them.
Okay.
And it's the same with this one. Like, I give you a due date because there's students who really like due dates. I like due dates, and then I don't want you to get behind. But I also realize that it's an online class and people miss things, and that's all right.
My internet.
And so just submit them when you're ready.
Okay.
So today's lab quest should be open right now. And it will open and be open through next Thursday night at midnight. And it's covering lab exercise 30 and lab exercise 29.
No.
The case study, I haven't opened it yet. It's not even posted there yet. It's gonna, I haven't honestly put it together yet. I'll put it together after class today. But it will include things about the blood, the lymphatics, and the heart structure, and possibly blood vessels. Actually, not specifically blood vessels. We'll probably hold off on that, but it will be about the heart. And if you have questions about it, what I'll probably do, I'm saying I put here due date would be next week, but I think I'm going to leave it open for another week.
That would be great.
Yeah, I think it's a good idea, because then you can bring questions if you want to lecture. And we can discuss it then. But like I said, there's never really on things on the Dropbox, I don't close them. So they really can be submitted at any time. Any questions? Let's jump into this. one thing that you will see, and I'm trying to make your lab questions a little easier. I want you to do them because I want you to put the work into it, because it also helps you study for the lab quests. And just by doing it, you learn. But I'm trying to make them a little easier for you also. And one thing that you'll see, and I'm going to try to do it every week, it takes time. And so it's more that I kind of got this class at the very last moment. Normally I would take easily two to 3 months to prepare a class that I'm walking into teaching for the first time, like this one. And I had, for this class, I had about a 2-week notice. And therefore, a lot of this, I kind of go by the seat of my pants with this class. And a lot of your PowerPoints, you'll notice they don't get put up until the night before class, because I'm still getting them ready. And the reason I tell you that is because to try to make the labs a little easier and make Wiley a little easier, I've learned that I can actually copy their figures out of the questions and put them in the PowerPoint. And I didn't know that up until about 2 weeks ago, or actually it was about a week ago. And so for especially the ones where they ask you to diagram something or identify, bear with me here, I'll show you. It'll be easier for me to show you than to just say it. For example, so this is the lab exercise questions for this week. There's already been some people who have already submitted them. Actually, no, this was last week's. So this week's lab. Looking at the questions. Options, student view. So if you start the assignment, and the first thing you do is you start seeing pictures and they ask you to identify. If I couldn't find one that was very similar in your textbook, I grabbed the same figure, at least for this week. I grabbed the same figure and I edited it, and then I put it into the PowerPoint and labeled it. So when you're doing these, rather than sit there and stress about how to answer them, really look at the PowerPoint, because the answers are there.
Yeah, I struggle with this sometimes.
That's why I'm saying spend the time with the PowerPoint. Okay. Because the answers are all there.
Gotcha.
And I'm trying to make it easier for you. I want you to do it because it also helps you study. but the answers are all there. And one thing, I'm gonna keep going. This figure right here, coming from a cadaver. It's on the PowerPoint and it's all labeled. And I'll show you right now where it's at when I get there. So here's the PowerPoint. Can't remember exactly where it is, so I'm going to scroll down a little bit because I think it's towards the end.
It's slide 31.
Is it? Okay, it's slide 31, so I went too far. All right. So it's right there and it's all labeled with the answers. So don't stress so much about that. Work on learning them, but at the same time, exactly how they're labeled there, outside of the A, because there's arteries outside of the A there. The answer for, I think it was 1, 2 is the right common iliac. The 1 for 3 is the right internal iliac, and so forth. So as I get more comfortable with Wiley, I figure out there's things I can do that I didn't know I could do before. And this is one of them. I would have been doing it last semester if I'd realized I could. So, all right, I'm going to go to the beginning here, but I just wanted to show you that there are a lot of these. I think this is also one, that it's the same thing. Yeah, it is. So I just took out the numbers and replaced it with the answers. So this lab specifically is talking about identifying the blood vessels, and the last part talks about capillary exchange. Those different pressures that we talked about last week are coming up again in this lab exercise. So there's different naming patterns for blood vessels. They're named kind of in a lot of ways. They're named, there's a pattern to the naming. Parallel blood vessels. So a lot of times we have a right and a left of a blood vessel. Like we have a right brachial artery, we have a left brachial artery. We have a femoral artery, right femoral artery. We have a left femoral artery. We have a right femoral vein. We have a left femoral vein. Many times they're also named for the areas that they pass through. For example, femoral, if you think about where your femur is, your right femoral artery and your left femoral artery are running in that same area. Your right subclavian artery and your right subclavian vein are running right underneath your clavicle. They're all also can be named for what they supply or what they drain. Arteries supply, veins drain. If an artery or a vein runs through a particular area, it supplies or drains that area. We do have some unique vessels where they aren't paired with, their names are not paired with another artery or vein. For example, your median cubital vein. You don't have a median cubital artery, but this is the one that runs on your arm, in between your arm, that they like to draw blood from, your median cubital vein. You don't have an artery with that name, but median cubital, this is your elbow cubital. Median meaning it runs through the middle of your elbow. So named as they pass anatomical landmarks. You have external and internal. You have external arteries, internal arteries. External veins, internal veins. You have superficial arteries and deep arteries. Superficial veins and deeper veins. We have common arteries. Common meaning they are going to split. Every time you see the word common, it means that that artery or vein is going to split. I'm trying to think if I know of one that's a vein. I can't really think. Oh, yeah, I guess I can. But anytime you see the word common, it means that ultimately that's going to split into one or more, into two or more different vessels. Or if it's a vein, it's a merging of two or more vessels. Proper meaning it's a direct route. Like the hepatic proper artery or proper hepatic vein is the one that's directly, we have a common hepatic vein, meaning it's going to split. And then we have a proper hepatic vein, meaning that it's directly going to the liver. It's the direct one at that point. Trunks are kind of like common, like your pulmonary trunk. It splits off into your pulmonary arteries. So trunks meaning they're going to split. Just like a tree trunk, they're going to split into different branches. Arches meaning like circular golden arches, like McDonald's, arching vessels. Collateral. You've heard of collateral damage, like damage off to the side that wasn't maybe not intentional, but happened anyway. Have collateral arteries and veins. Circumflex meaning they're going around. Remember the circumflex artery that's part of coronary circulation. It's going around a structure. Anastomosis, a coming together of different arteries and veins. An anastomosis. So an overview of Arteries, remember, arteries become arterioles. Arterioles become capillaries. Capillaries drain into venules. Venules drain into veins that then move back towards the heart. So arteries, blood's leaving away from the heart, branch off into arterioles. Remember, we had those meta-arterioles too, but we're not going to worry so much about these today, meta-arterioles today. But capillaries then become venules that then become veins. Major differences between arteries and veins. Anytime you're looking at a cross section between an artery and a vein, the easiest way to know which is arteries maintain their shape. They look like circular vessels. Veins often look a little smashed up. They just don't maintain their shape as well because they don't have as much muscle. They don't have as much elasticity. They don't have as much muscle. So differences between pulmonary circulation and systemic circulation. Remember, arteries are always carrying blood away from the heart. Veins are always bringing them back. So how does this make what we see in pulmonary circulation different? What that means is this is the only place in the body where we're going to see arteries carrying deoxygenated blood and veins carrying oxygenated blood back to the heart. Because that's where the air is the gas exchange is occurring to add oxygen to the blood. In systemic circulation, the majority, it's mainly to remove, it's only to remove oxygen from the blood and pick up carbon dioxide. But in the case of the pulmonary, the arteries are taking the blood into the lungs to get oxygen added to the blood. And the veins are bringing it back.
I have a question about that.
Go for it.
Are the systemic then arteries and veins different? Because I noticed like the way they were labeling them, normally it would be red for artery, veins being blue, but
right
in those cases, the colors were switched. So that was throwing me off.
That's the only reason, is because what they're trying to tell you is that the blue blood is oxygen poor.
Right.
Or deoxygenated. And the red blood is oxygen rich. And in the body, in systemic circulation, the arteries are carrying oxygenated blood and the veins are carrying deoxygenated blood or blood with less oxygen in it. However, in pulmonary circulation, it's the opposite because the arteries are carrying the blood from the heart to the lungs to get oxygen put back in the blood.
Okay, that makes so much sense. Thank you.
Of course. So, overview of arteries of the upper body. Starting at the top, remember the temporal bone. So there's the superficial temporal artery. the facial artery. We have an external carotid and an internal carotid. Internal carotid is going to go up towards the brain. External carotid is going to come out towards the face. They branch off from a common carotid. Remember what I said about common? It means that it's going to split. So common carotid artery splits off into the internal and the external carotid arteries. Another artery that we have that's coming up the neck is the vertebral artery. If you remember, on all of the cervical vertebrae from last semester, they have a little hole called the transverse foramina that kind of go up the sides of the cervical vertebrae. That is where the vertebral artery goes up into the brain, is it follows that pathway. And we'll see it again in a moment here. The brachiocephalic trunk. 3 main arteries coming off the aortic arch. The brachiocephalic trunk, the the left common carotid artery, and the left subclavian artery. As the subclavian artery starts moving down the arm, it becomes the axillary artery. Remember, axillary means armpit. So the same artery is named different things depending on where it's at. Axillary artery because it's moving by the axilla. Subscapular artery moving down behind the scapula or underneath the scapula. The brachial artery. The radial and the ulnar artery. Radial moving down the side of the radius. The ulna moving down the side of the ulna. So the brachial artery is going to split into the radial artery and the ulnar artery. Coming back up, starting at the aorta. It arches down, and remember I told you can feel the pulse. If you kind of stick your finger right below the manubrium, you can feel the pulse of the aortic arch or the aorta. So coming right down, moving down. In this area right here in the thoracic cage, here's your diaphragm. It's the thoracic artery. It's we call it the descending artery or the thoracic artery. Ascending artery right here, aortic arch, descending artery. When it's in the chest area, it's the thoracic artery. As it moves past the diaphragm, it becomes the abdominal aorta. I'm sorry, I think I called it the thoracic artery. It's the thoracic aorta. As it moves down, it becomes the abdominal aorta, because now it's in the abdominal cavity. Right here, and it's not labeled here, but there's 3 main unpaired branches that are coming off the abdominal aorta. There's the common hepatic, the splenic artery, Splenic meaning it's going to go towards the spleen and the left gastric artery. And they're coming off what's called the celiac trunk right here. It's not labeled here, but it'll be labeled later. The renal artery, we have a pair of renal arteries, the right and left renal artery, renal meaning kidneys. So these are going to go to the kidneys. If you're looking at a picture of an artery and it's branching off and connecting to the liver, excuse me, with the kidney, it has to be the renal artery. Does that make sense? So make your memorization a little easier. If it's the splenic artery is going to connect with the spleen. Splenic vein is going to come back from the spleen. The renal vein is going to come back from the kidney. The next one that's unpaired is a superior mesenteric. Mesentery meaning your intestinal area. It's going to supply blood to the right part, a large part of your large intestines and small intestines, but specifically on the right side and the top half. The inferior mesenteric is going to do the bottom part of the intestines and part of the left side. The gonadal arteries are going to the gonads. As we move down, the abdominal aorta is going to branch. And it's going to branch into the common iliac artery. When we know it's common, we know it's going to split. If you remember when talking about the bones, what is this area right here? On most of us, you can feel it. What's this bony landmarking right here?
Your pelvic.
Okay, give me the scientific word that's not pelvis.
Ischemic.
What?
Yeah.
Ischemic. Ismic.
You're close. You're really close. Bear with me here. You're gonna see some skin, so don't get too appalled. Look. Oh, come on, you stop. You guys, what's this area right here that comes right through here?
The iliac.
The iliac crest, right?
Right. The ASIS.
Okay. Hope you didn't get too blinded. I was trying to think, how do I show that to them? That was the best way I could think about.
You're lean. If you wouldn't even be able to see it on me.
I just don't have any curves is what it really is, Claire. That's what it really is. I'm kind of made like a boy, but we won't say anything. My mother doesn't like me to say that. It is kind of true.
Oh,
Gotta love mom in the background. It is not true.
So looking here again, so here's the abdominal aorta. It branches off into the common iliac because that's where the iliac crest is, and becomes the internal iliac, which is going to move into the pelvic cavity, and the external iliac, which is going to move down the leg. Do you see how things are named similarly? Looking down at the bottom here, you have the femoral artery as the external iliac is moving down, becomes the femoral artery. And then we have a deep femoral artery here. There's actually a femoral circumflex artery right here. You see it's making a circle. It's a circumflex artery. So femoral artery coming down. Behind the knee is the popliteal artery. Moving down even further, in front of the tibia is the anterior tibial artery. Behind the tibia, because the popliteal artery, it's gonna come from behind, it's gonna go behind, and then it's gonna branch out. It's gonna come up anteriorly and branch down and become the anterior tibial. Well, popliteal artery divides into the anterior tibial artery that comes around the front of the tibia and the posterior tibial artery running down the back. Posterior tibial artery is going to branch off from the fibular artery. It's going to run next to the fibula. And then we have the dorsal artery. You remember, this is the part of your foot that you're looking down at when you're looking at your toes is the dorsal side of your foot. So that's the dorsal, it's actually called the dorsal pedis because it's a foot. Dorsal pedis artery. Questions? So this is showing all those arteries one more time. And in the case of the systemic circulation, like Zena asked earlier, arteries are carrying oxygenated blood in this case, and veins are carrying the deoxygenated blood. So they tend to depict arteries as being red and veins as being blue. I can tell you that in real things, in real organs, that isn't the case. However, arteries, you can almost always tell a difference between an artery and a vein because arteries maintain their structure. They maintain their circular structure. Veins tend to end up with the blood pooling in them upon death. So looking at the veins of the upper body, we don't have carotid veins. We have the external and the internal jugular veins. Someone asked me at some point if they merge together, and they don't. Looking at this diagram, I think somebody asked me that in my anatomy course at Stevenson, and they don't. This is the external jugular is the one you can often see. at times, depending on how hard my heartbeat is and how maybe dehydrated I am, I can see this pulsing. Actually, it's not that pulsing. It's your common carotid that you're seeing pulse on the side of your neck. Brachiocephalic vein, right here. You have two brachiocephalic veins. So you have one brachiocephalic trunk, but you have two brachiocephalic veins. It's a really great true or false question. So one brachiocephalic trunk that comes off the aorta. You have two brachiocephalic veins that are going to merge. Those brachiocephalic veins are going to merge to form the superior vena cava.
Can you repeat that?
Yep. So you have one brachiocephalic artery that comes off the aorta. You have two brachiocephalic veins. You have a left and a right one. And the two brachiocephalic veins are going to merge. They're going to drain the arms and the head, and they are going to merge to form the superior vena cava. Brachiocephalic, what does that mean? Brachio meaning arm, cephalic meaning neck. So it's draining the head. Actually, cephalic means head and neck. So cephalic meaning it's draining the arm and the head and neck.
Thank you.
Of course. Where else? Let's see here. So moving down, let's do part of the arm here. So brachiocephalic vein, I'm going to start down here because remember, arteries are moving out this way from the heart. Veins are bringing it back. So starting out on the outer arm, you have a cephalic vein. Cephalic means on top. You have a cephalic vein. If I'm in anatomical position, actually, let's do this. Anatomical position. Cephalic is going to be on top, right? Basilic is underneath. Because basilic means basement. The median cubital vein links these two together, the cephalic and the basilic. So cephalic, I can almost see it on my arm. I think that's it. A little purplish one right there, bluish one. Basilic is going to be up here, and they're going to merge. You can kind of see the basilic. They're going to merge with the median cubital right here, basilic, cephalic. So merge together, forming the median cubital. Median cubital moving up, becomes the brachial vein, which then becomes the axillary vein, which then becomes a subclavian vein. Which then feeds into the brachiocephalic vein, or drains into the brachiocephalic vein. Down on the lower part of the arm, you also have a radial vein and an ulnar vein running down by the radius and the ulna. Moving down, so here's the superior vena cava, here's the inferior vena cava. Hepatic veins draining the liver. The renal veins draining the kidneys. The gonadal veins draining the gonads. The inferior vena cava, just like the abdominal aorta, is splitting or merging from the two common iliac veins, which are formed by the merging of the internal and external iliac veins. Questions? In your arms, you have, in your hands right here. I think we see them again. But venous palmar arches on the palm, dorsal venous network, which you can see on the back of people's hands. See it on the back of people's hands, the prominent veins that come out. Dorsal venous network. Dorsal venous network. So femoral vein, popliteal vein, just like we saw with the arteries. Femoral vein, deep femoral vein, popliteal vein, anterior tibial vein, and the posterior tibial vein. We have two veins down here that are not paired with arteries. The great saphenous vein, which is the longest vein in your body, that comes all the way from up here, all the way down to your ankle. That's the great saphenous vein. That is the one that they like to take tissue from when they're doing coronary bypasses. I'll tell you, it's a royal pain in the butt to try to dissect out of a cadaver, because it's very, 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 very shallow and tiny. I think I've done a lot of leg dissections, and I'm yet to be able to dissect that little bugger out without cutting it. Because it's very shallow and it's very tiny. The small saphenous vein is on the outer part of the leg. And it's just down on the lower leg. There's an overview showing those. Questions? Review coming off the heart. Brachiocephalic trunk branches off into the right common artery, common carotid artery, and the right subclavian artery. Left common carotid artery, left subclavian artery. Two major branches that come off right immediately after the aortic semilunar valve is the right coronary artery and the left coronary artery. Questions? So I got asked in my class the other day, we were in my class at Stevenson, which in a lot of ways is parallel with what you learn here. A little different because they learn anatomy in a separate course and they learn physiology in a separate course. So they're not combined. But they take anatomy first and then they take physiology. And something that came up in that class is, oh, what did she call it? Blue baby syndrome. And it's not where they don't develop enough surfactant. Bear with me, I'm going to look up the title of what it is. It's a movie, and if you haven't, what? Arterial. I don't think that, is it that? I thought it was that the pulmonary trunk is. I'm
guessing because blue baby syndrome is very strange. I'm not familiar with that.
I don't think that's the right term either. I'm trying to remember. So there's a movie that came out, it's an older movie, but it's an awesome movie. That's called Something the Lord Made. And it's really not religious. I'll tell you, it's not a religious movie. However, it is about the first heart surgery that was ever performed. And it was performed on a baby. And what they did is it happened here at Johns Hopkins. And there was a dogma behind it with the heart that you don't touch the heart. with surgery, you don't touch the heart. And that's what they went up against, was the fact that could you do surgery on the heart? And bear with me here just for a sec. Disease treated, disease fixed, treated, and something all. Oh, wow. See, I didn't know, Mom, it is blue baby syndrome. Yeah. Teratology of Fallot. Of Fallot. I didn't even know they knew how to cure that. All right. So I guess they were working with teratology of Fallot, which almost always, even now, is a lethal defect. And what I think it is, and now that I'm learning what it really is, I'm realizing how little I know about it. What they were doing was they were what happens is the babies just slowly die of hypoxia. And it I thought, and now I've got to study up on it because I thought I knew more than I did. I think it has to do with pulmonary trunk stenosis. But now I'm not sure. So I'm going to quit going down this tangent because I don't know what I'm talking about.
It has to do with
Multiple heart defects?
Very specific defects.
Okay. So I'm learning. I knew it. I thought I had it down because I had a student ask me about it yesterday in a class. And I thought I knew what she was talking about. And now I'm realizing I know very little. But multiple heart defects having to do with the blood vessels. And the babies slowly die of hypoxia is the end all result. And even now, this movie, I'm trying to think when I cannot remember when they actually did the first surgery. But it was back in the 50s, maybe. And 1940s. And to this very day, it's often a lethal defect. So what they were doing was trying to repair this. And now I wish I hadn't gone off on this tangent because I realized how little I know about it. But if you look it up, you realize that even to this very day, it's a lethal defect. I follow a group on Facebook that has to do with people struggling with a lot of different issues. And that's one that you see on there a lot, are people who are pregnant realizing that their baby's going to have that. So, all right, I'm sorry. I'll come back from that tangent. I thought it had to do with the pulmonary trunk. I think that's what it has to do with in that movie. But talking with my mom, it's a combination of and a wide range of defects to do with the vessels. But it's an amazing movie in that they were doing things that nobody believed they could possibly do. How would you stop the heart and get it going again?
Anybody who did touch the heart and stopped it could lose their medical license.
Anybody who touched the heart and stopped it could lose their medical license. And so if you want to see a neat movie, see that movie. It stars Alan Rickman, who played Snape in Harry Potter. He died a couple of years ago, but he's one of the two main characters in the movie. So coming back, sorry, realizing how little I knew about that, what they were doing there. I thought I knew more than I did. Superficial temporal artery, moving up the next to the temporal bone. Maxillary artery. Occipital artery. Facial artery. The internal carotid artery going up towards the head, the external carotid artery. Here. External carotid artery becoming the facial artery, which then is going to become the superficial temporal artery. The coronary sinus, or not coronary sinus, carotid sinus, where the two external and internal carotid arteries are going to merge from that common carotid artery. So I told you the vertebral artery runs up the transverse foramina of the cervical vertebrae. Brachiocephalic trunk becoming the common carotid. Excuse me, the right common carotid and the right subclavian. Then it becomes the axillary artery. So this is just a diagram showing the network and the flow from the aortic arch into what we call the circle of Willis right here, which is in the brain, and we'll see it in, I think, in the next slide. So the circle of Willis, here's your vertebral arteries right here. Remember, they're coming up the neck through the transverse foramina. They're going over the pons. And as they go over the pons, they merge into the basilar artery. The basilar artery comes up into this circle here. And we have the posterior cerebral arteries. Posterior cerebral meaning brain, so posterior cerebral arteries. The posterior communicating arteries. The middle cerebral arteries coming out towards the middle. Going in between the temporal lobe and the frontal lobe here. The anterior communicating artery and the anterior cerebral arteries going out towards the front of the brain. Questions? I do not think, if I remember right, I do not think that this is in your lab exercise. I think it's important to go through, but it's not in this lab exercise. For some reason, they leave it off here. So I'm going to go through it fairly fast. I think you also saw it in a little bit in 121 when we talked about the brain. So moving down, how do we drain the blood from the brain? The internal jugular vein, the sigmoid sinus. External jugular vein is going to drain the rest of the head. The internal jugular vein is going to drain the brain area. These major sinuses, confluence of sinuses, where the blood is pooling back. Remember the superior sagittal sinus that goes down the longitudinal fissure of the brain. Questions? So just like we saw with the arteries, we're going to have a lot of matching veins here. Superior temporal vein, occipital vein, facial vein. The facial vein and the superior temporal vein are going to drain into the the internal jugular vein, and I apologize, the internal jugular vein is going to drain the brain and the face. The external jugular vein is just draining the back of the head and part of the face. The brachiocephalic vein, subclavian vein, axillary vein. So we saw some of these before, looking at the arteries of the upper trunk. The aortic arch, the brachiocephalic trunk, which becomes the right common carotid and the right subclavian. One of the branches off the right subclavian is a subscapular artery, meaning it's moving behind the scapula. The vertebral artery, remember that's moving up through those transverse foramen in the cervical vertebrae up towards the brain. The two arteries that feed and supply the brain are the internal carotid and the vertebral artery. Are going to supply that circle of Willis up here in the brain. the left subclavian artery, aortic arch, descending aorta, some esophageal arteries here. Showing the branching network. What becomes what? So just the arteries of the abdominal area. Here's the diaphragm right here. Inferior phrenic artery. Remember, what does the phrenic nerve innervate? Do you remember from last semester?
The stomach?
Nope, nope, nope. What else could it do? If
The
you
lung?
sever it, you die.
The
Oh,
lung,
that's right.
diaphragm.
The diaphragm. It's the
Then you can't-
diaphragm.
Breathe, you're phrenic.
Yep.
Good
You're-
one.
That's how I remembered that. Obviously, it didn't resonate that well.
If you can't breathe, you're frantic. All right, that's funny. Okay. Celiac trunk. So 3 main unpaired arteries coming off the abdominal aorta. Celiac trunk, the superior mesenteric artery. These are unpaired. So celiac trunk, superior mesenteric artery, and the inferior mesenteric artery. Those are the three unpaired arteries coming off in order. Celiac trunk, superior mesenteric artery, and inferior mesenteric artery. Renal arteries going off to the kidneys. Suprarenal going to above the kidneys. Well, what gland is above the kidneys? The adrenal glands. So the suprarenal arteries are going to the adrenal glands. Getting a good close-up of the celiac trunk and also the superior mesenteric, which is coming off later. Celiac trunk right here. Here's the abdominal aorta. The 3 main branches coming off the celiac trunk are the left gastric going towards the stomach, gastric meaning stomach, the left splenic, or excuse me, not left splenic because we don't have a right one, the splenic artery going to the spleen, and the proper hepatic artery or hepatic artery proper. However, depending on who you talk to, they say it differently. Your manual calls it what I typed in there. The proper hepatic artery. Cystic artery going towards the gallbladder. Hepatic artery going towards the liver. So here's the celiac trunk, left gastric artery, splenic artery, and the proper hepatic artery that's not labeled here. And one of the branches coming off the proper hepatic artery is the right gastric artery. So you have a left gastric artery and a right gastric artery. You'll see I'm not going through all of them because some of them, you have enough to learn right here. For we're not going through all of them. So showing the branching network, celiac trunk, becoming the left gastric artery, the splenic artery, and the common hepatic artery. Should take in my teaching assistant. Darn it. She's kind of gassy, just so you know. What's here? Here's the, so remember the three main branches, unpaired arteries coming off the abdominal aorta, the superior mesenteric, the celiac trunk, and the inferior mesenteric. Superior mesenteric is going to do much of the large intestines, some of the small intestines. The inferior mesenteric is going to do part of the small intestines and part of the large intestines. Veins of the thoracic cage. Two brachiocephalic veins merge, becoming the superior vena cava of the heart would be right here. Subclavian vein. Moving down, the ascus vein, and I'm going to look up really quick, what does ascus mean? Because you'll see this is, you're only going to see this in the thoracic cage. Ascus. I think I might have actually done it in the past because it's bringing it up very easily. Not being paired. I thought it meant, I knew that's what it meant. Not being paired. So the ascus vein, you only have one ascus vein. Moves up the thoracic cage. You have a hemiascus, meaning half of it right here. In addition to having a hemiascus, meaning half of this vein, you have an accessory hemiascus vein right here. And it looks like the ascus vein is going to drain into the superior vena cava. Looking at the veins of the abdominal region, the inferior phrenic vein, just like you have an inferior phrenic artery, you're going to have an inferior phrenic vein, which is feeding the bottom part of the diaphragm or draining the bottom part of the diaphragm. You have hepatic veins, about the same place where you have the celiac trunk, with the aorta that would be right here. This right suprarenal vein, the left suprarenal vein. The right and left renal veins. Inferior vena cava here, that's going to form from the common iliac, the right and left common iliac veins, which form from the internal and external iliac veins. The little vein that runs down right here, and I think it's the median sacral artery runs with it from the aorta, called the median sacral vein. Do you mind if we take 5 minutes? We get up and move around.
That's fine.
All right, let's get up and move around for a second.
Sounds good.
That sounds good.
So let's come back at 1:32. Okay. So looking at the veins that specifically are part of the hepatic portal. The hepatic portal, so the, bear with me, let me think here. The hepatic portal vein is going to be a stemming of multiple veins. It's going to be emerging of multiple veins that are going to that are going to drain into the liver. What does the liver do? The major purpose of the liver is detoxification. And so when we absorb things through our intestines, we absorb things, we absorb things in our stomach, we absorb in our small intestines or large intestines. All of this stuff that we're absorbing into the veins within the abdominal region are going to be drained into the liver, where the liver will filter it and detoxify it before it goes into the hepatic veins on top of the liver and remerge with the inferior vena cava to go up to the heart. It's going to get, it's essentially going to clean up the blood before you give it and move it into the heart. So like we had before, we have a lot of parallel veins and arteries. Abby, you can't be right there. Superior mesenteric vein, inferior mesenteric vein. The splenic vein, gastric vein. They're all going to merge into the hepatic portal vein, which is going to drain into the liver. Questions? So just a generalized view here, we're moving into the liver. All of these veins are going to drain into the hepatic portal vein, which is going to feed into the liver, allowing for detoxification of that blood before it moves into the inferior vena cava and up to the heart. General chest drainage of the veins diagram. So the heart would be. the ascus vein, the hemiascus, accessory hemiascus, hemiascus. Showing another depiction of that. Like I said, this is the picture that came from the questions that you're being asked. So when you answer that question, use this diagram because I gave you the answers right here. And same thing for this one. Here's the aorta. Here's the inferior vena cava. The spleen actually is behind here. Here's the renal glands, the adrenal glands, which are being fed by the suprarenal arteries and drained by the suprarenal veins. So the common hepatic, I'm realizing this right here, depending on where it is. Yeah, okay. I'm looking at this one and it looks like it's coming off here and it's not right. It's actually coming off right here because this is a celiac trunk. So here's the splenic artery. Here's the common hepatic artery. Here's the inferior mesenteric. Here's the superior mesenteric. So here's your three unpaired arteries coming off the abdominal aorta. Showing that branching network going down the arm, brachiocephalic trunk, common carotid, becomes the subclavian artery, which becomes the axillary artery, which becomes the brachial artery. Coming off the brachial artery and going around the humerus is the circumflex humeral artery. Remember, circumflex always means circumference or going around something. The deep brachial artery. The radial artery, the ulnar artery, the superficial palmar arch, and the deep palmar arch. Showing that same depiction. Veins, the external and internal jugular veins, moving into the brachiocephalic vein, which the two brachiocephalic veins are merging to form the superior vena cava. Subclavian vein, the axillary vein, which has a branch, the cephalic vein coming off, and the basilic vein coming off, which come together, the cephalic and the basilic vein, coming together to form that median cubital vein. Here's the brachial veins. So the cephalic vein and the basilic vein and the median cubital vein, we don't have matched arteries. Cephalic vein, basilic vein, and the radial vein and ulnar vein. The deep venous arch and the superficial venous palmar arch. Questions?
Nope.
Okay. Just an overview showing that same thing and how they're merging together and flowing. Allowing you to see them a little better. Median cubital, the cephalic, the basilic. There's also a median antebrachial, anti meaning on the front, going down the front of the arm. Arteries up the upper leg, the aorta, the common iliac artery, the internal iliac artery, and the external iliac artery, which is going to become the femoral artery. We have a circumflex, we had a circumflex humeral artery. We have a circumflex femoral artery. And a deep femoral artery with the femoral artery. A little further, femoral artery goes behind the knee, becomes a popliteal artery. The popliteal artery divides to become the anterior tibial artery coming out into the front and the posterior tibial artery. Posterior tibial artery is going to branch off into the fibular artery. The bottom of the leg, the deep plantar arch of the dorsal pedis artery. Showing an overview of them. Showing their networking, how they're supplying them, how the blood is flowing. Showing the veins. Saw these a little bit before. We'll see them again here. Common iliac vein branches off into the external iliac and the internal iliac vein. The femoral vein, the circumflex femoral vein. And the great saphenous vein, that's this long, long vein, longest vein in your body, comes all the way down. Comes the popliteal artery. So femoral vein is coming from the popliteal vein. The great saphenous vein that continues down. Remember, it's that long, long, long artery. Excuse me, long, long, long vein. The small saphenous vein, the anterior tibial vein, and the posterior tibial vein, and the fibular vein. Overview. Showing how how the blood is moving back. Questions?
No.
Okay. So major pulse points. The superficial temporal artery, the facial artery, the common carotid artery, the radial artery, the brachial artery, the femoral artery, popliteal artery, posterior tibial artery, and dorsal artery. A lot of times, and my mom has told me that you can't, she's never felt all these pulse points. But many times, if you're worried someone's been injured and you're worried about making sure that they haven't gotten any, there's a, whether or not there's a consistent blood supply to a particular extremity. You'll look for these pulses, and if you can't feel a pulse, you know there's no blood going to that area. A lot of times they'll do it with the femoral artery. There's no pulse going. If you can't feel a femoral artery pulse, you know there's no blood going to the leg.
I know when I worked in the hospital, there was a lot of patients, because I was in the cardiac, that had edema, and they did a lot of the, like, I guess the post-tibial and the dorsal for their pulses to make sure that they could feel them.
Oh, okay.
Yeah, it was crazy, but they're like, because of the swelling and stuff, they wanted to make sure they were still getting good blood flow and pulses to their lower extremities.
Wow.
Yeah, it was interesting.
I don't think I've ever felt them back there. Like I felt the radial artery, I felt the brachial artery, I felt the common carotid. I think I felt the facial and the superficial temporal, but I've never felt the other ones down here.
Yeah, and sometimes they would get out like the little Doppler to see if they could even hear it.
Really? Wow.
Yeah, depending on how bad the edema was. Oh, my dog's barking. Hold on.
That's okay. This is a figure right from the manual. It's asking you, so we know that fetal circulation and some structures change after birth. We saw when we were talking about the heart in lab, and a little bit in lecture, maybe, no, specifically in lab, the ligamentum arteriosum. It's a little connection between the aortic arch and the pulmonary trunk. that is a ductus arteriosus in the embryo. The foraminal valley, which becomes the fossa ovalis, and this was, Zena, this is the one that didn't close over in your daughter. She knows. A lot of, sometimes that is a little flutter valve, and it may not close in a child after they're born. And then they have to go in there and repair it. Or you get a mixing of deoxygenated and oxygenated blood. The ductus venosus becomes the ligamentum venosum. Umbilical veins become the ligamentum teres. The umbilical arteries become the medial umbilical ligaments. So this is a little bit of a review from last week, but I know that some of your questions in your lab exercises are going to address these again. So I thought we'll go over them again because it'll make when we go over blood vessels even easier, or blood vessel structure and lecture, it'll be even easier. So 3 basic types of capillaries: continuous capillaries, fenestrated capillaries, and sinusoid capillaries. Continuous, meaning we have tight junctions and a continuous base membrane. So tight junctions between the endothelial cells and a continuous basement membrane. In fenestrated capillaries, we have little fenestrations in the endothelial cells. In the discontinuous capillaries, it's a discontinuous or absent basement membrane with large holes in between the endothelial cells. Looking at the capillaries, endothelial cells, it's a cross section here. So substances like looking at things that can move through the capillaries and what can't. Plasma proteins are stuck within the blood. Oxygen and carbon dioxide and other lipid-soluble molecules can pass through the endothelial cells. Small water-soluble molecules like sodium, potassium, glucose, and amino acids can pass through the pores of the endothelial cells. We can sometimes move things via transcytosis. Remember that from last week? Being able to move things via vesicular transport. You take them in on one side, endocytosis on one side, move them across a cell, transcytosis, exocytosis on the other side. So when we look at fluid movement in and out of the cell, or solutes and ions moving in and out of the cell, there's pressures that are going to determine whether or not fluid moves in or out of the cells. excuse me, in or out of the capillaries. These are called the Starling forces. There's a capillary hydrostatic pressure. When you think hydrostatic, think blood pressure. So there's a capillary hydrostatic pressure, which is the pressure of the blood or the blood volume within the capillary. There's the interstitial hydrostatic pressure, which is the pressure that's being exerted by the fluid out here surrounding the capillary. There's the plasma colloid osmotic pressure. So this is the pressure that's exerted by the proteins within the capillary that are trapped there to bring fluid back in. And then there's the interstitial fluid colloid osmotic pressure, which is the pressure to pull things out of the blood, into the interstitial tissue. Questions? So we have these different opposing forces. Depending on the values of these different forces, it'll depend on whether fluid moves into the capillaries or out of the capillaries. At the arterial end, where the fluid, the hydrostatic capillary pressure is the highest, the result is that the blood colloid osmotic pressure is lower. Actually, bear with me here. Make sure. On the arterial end, we're next to the arterial. The capillary hydrostatic pressure, the pressure to move things out, is higher than the pressure to bring things in to the capillary. And the result is that the net movement of fluid is to move out. When the capillary hydrostatic pressure equals the blood colloid osmotic pressure, then there's no net movement in or out of the capillaries. When the capillary hydrostatic pressure is less than the blood colloid osmotic pressure, which is higher, fluid will get reabsorbed into the venule end. And the result is that you get fluid being brought back in. What is bulk flow? What's edema? Bulk flow is the net movement of fluid in or out of the vessel. Is the net movement going into the vessel, the venous end, or is it the net movement going out? Edema is when just for a second. I knew up until a second ago. Edema is when the blood colloidal osmotic pressure is not higher at the venous end than the hydrostatic pressure. And the result is that the fluid isn't drawn back in to the vessel, to the capillary here. That's what edema is. When the blood colloid osmotic pressure is not high enough or higher than the capillary hydrostatic pressure, the result is that the fluid is not drawn back in at the venous end, and it's left out in the interstitial tissues. That is a big dog, Becky.
He's only 15 weeks.
Oh, yeah.
It's a German Shepherd.
Oh, he's probably adorable. Okay. My dad has one. They're like little baby Tyrannosauruses.
He is, and I had him out today because he does better. So I've had to pause my video and take him outside because he's working on the potty training. He's doing good, but it's still, I'm in my bedroom and I'm like, yeah, you're not doing that on my carpet.
Why not, Becky? Why not? I don't get it. I don't get it. So net filtration pressure is, by definition, the amount of movement in or out of the vessel. When the net filtration pressure is positive, that means that fluid is going to get moved out of the capillary. When the net filtration pressure is negative, it's going to get reabsorbed. The pressure to move things out is the sum of the hydrostatic pressure of the blood plus the oncotic or osmotic pressure of the tissues. Minus the hydrostatic pressure of the tissue plus the osmotic pressure of the blood. So when the net filtration pressure is positive, that means that fluid is going to move out of the capillaries. When it's negative, that means that fluid is going to get reabsorbed. This is the hydrostatic pressure of the blood. This is the oncotic pressure of the tissues, or osmotic pressure of the tissues. This is the hydrostatic pressure of the tissues. This is the osmotic pressure of the blood. Bear with me just for a second here. So here, if the hydrostatic pressure within the blood is 35 millimeters, and the tissue osmotic pressure is 25, the result is that there's going to be a net filtration out of 10. If it's if it's positive, it's going to move the fluid out. If it's negative, it's going to bring it back in. On this side, the hydrostatic pressure, hydrostatic pressure of the tissues out here, plus the osmotic pressure of the blood. So we're dealing with four different pressures here. Hydrostatic pressure of the blood. How much are we pushing the blood out of the capillary? Plus the osmotic pressure of the tissue. How much are the proteins out here in the tissue trying to reabsorb the fluid? What's their pull? Minus the hydrostatic pressure of the tissue, plus, which is how much of a push is there to move fluid back in. And the osmotic pressure of the blood is how much are the proteins within the plasma trying to bring that fluid back into the blood. Now, bear with me. That's the end of the PowerPoint. I'm going to do something really quickly here. So, plasma or hydrostatic pressure of the blood or plasma is the pressure that the blood or the pressure of the fluid within the blood that is exerted on the walls of the capillary. Exerted on the inside walls of the capillary. That's the hydrostatic pressure of the blood or plasma. Bear with me just for a second. I'm going to do this a couple times. The hydrostatic pressure of the interstitial fluid is the pressure of the fluid in the interstitial, pressure of the interstitial fluid that presses upon the outside of the capillary. Or let's say it this way, that is exerted on the outside of the capillary. So this is the hydrostatic pressure. This is the HPB on that slide. That's what that is. The hydrostatic pressure, and remember this B is low, is not it's lower. Remember, it's not lowercase, but it's in font. It's put down below. I can't remember.
Yeah, like it's like a subunit type thing.
Kind of, yeah. The hydrostatic pressure, IF here, the osmotic pressure of the blood or plasma is the pressure of the solutes within the plasma or blood that is exerted to bring fluid back into the capillaries. The osmotic pressure of the interstitial fluid is the pressure of the solutes within the interstitial fluid to pull fluid that is exerted to pull fluid out of the capillaries. So one thing to keep in mind here, these two, the osmotic pressure of the interstitial fluid and the hydrostatic pressure of the blood, are both working to pull fluid out of the capillaries. The hydrostatic pressure of the interstitial fluid and the osmotic pressure of the blood are both working to pull it back in to the capillaries. Is that clear? So I'm gonna change just a few words here. So exerted on the walls of the capillary to move fluid out of the capillaries, to move fluid out of the capillaries. So this is the pressure exerted on the inside capillary walls. Sorry, I think of better ways to say it as I type it. Inside capillary walls to move fluid out of the capillaries. The osmotic pressure of the interstitial fluid is the pressure of the solutes in the interstitial fluid that is exerted to pull fluid out of the capillaries. So if you see both here, we have fluid out of the capillaries, fluid out of the capillaries. These are just both working to pull fluid out of the capillaries. The hydrostatic pressure of the interstitial fluid is the pressure of the interstitial fluid that's exerted on the outside of the capillary to move fluid back in. Back in to the capillaries. Or yes, to move fluid back into the capillaries. The osmotic pressure is the pressure of the solutes within the blood that are trapped within the blood that is exerted to bring fluid back into the capillaries also. So keywords here: fluid moving out of the capillaries, fluid moving out of the capillaries. Hydrostatic pressure of the interstitial fluid and the osmotic pressure of the blood are both working as pressures that are going to bring the fluid back into the capillaries. Becky, does this work?
It does.
Okay.
I mean, I was like, I started to write it down and then you went back and I was like, I still understand it from my.
All right, good, because I'm sorry for going back. I kept thinking there was a better way of putting it.
There always is, but I like the two go together and the other two go together. So that's
okay
for me. I get it.
Okay. So
and I'm actually been pretty good this entire period taking pictures so I could go back and then review everything.
So the net filtration pressure is the sum of these all together. The negative and the positives. If it comes out to be positive, that's the fluid's going to move out. If the sum ends up being negative, the fluid is going to move back in.
So if it's negative, it goes out.
Right, because it's the, bear with me here. IF. So net filtration pressure, or NFP, equals the hydrostatic pressure of the blood, BB, plus the osmotic pressure of the interstitial fluid, minus the hydrostatic pressure of the interstitial fluid plus the osmotic pressure of the plasma. So if this ends up being the bigger value, this sum together ends up being the bigger value, then the net filtration is going to be negative. And so the result is that you're going to draw fluid back into the capillaries. This is, you guys, this is going to be really important later. When we talk about the kidneys, this is going to be really important then. It's important here, but it's even more important then. If the value is positive here, and this value is greater than this value, these values, then the net result is that there's going to be a net outward movement of fluid, because this net filtration pressure is going to end up being positive. Does this work?
Mm-hmm.
Awesome. Okay. Write this, you guys, make a mental snapshot of this. We're going to see it again next week in lecture, hopefully next week in lecture. We're going to see it again when we talk about the kidneys, because they work the same way.
I just took a screenshot of it.
Awesome.
So did I.
Awesome. I think I'm going to go back when we're done today and I've recorded this and processed it. I'm going to go back and write these down because these are really good. Good definitions. I might have it on another PowerPoint somewhere, but these are good. All right. This is the end for the lab. And so what I want to do is I still want to spend the last 14 minutes going back to lecture and doing a little bit there. I'm sure you guys are a little brain dead, but we are behind in lecture. And it's good discussion. And I like the fact that we have a lot of discussion. But I also want to see if we can get a little bit more done.
Sounds good.
Let me know. Let me know if those slides that I adjusted for the PowerPoint don't help you with lab, because they should, because I went in and started doing some of the questions and it was telling me my answers were all correct.
When should we be taking the quiz for the chapter 19?
Say it again.
Well, sorry, I'm having an allergy attack and I sound weird, but when should we be taking the test, the quiz for chapter 19? Like anytime? Or
you can take it any time.
Okay.
Chapter 19 part. Bear with me, twins. What? Toyin?
See, I did chapter 19 yesterday, and I know for some reason we weren't all the way done, so
We weren't. No, and we weren't finished because we're behind.
Oh, okay, because I was like, wait. I was going back and forth between my notes, trying to answer the questions. I was all over the place because I thought it was due today. That's why I tried to.
Well, and it shouldn't have been due today. Oh, you know what? It would have been.
Okay.
I'll push it back. Do you want another attempt, Casey?
Yeah. I didn't do bad, but I didn't do
great. I will give you another attempt, but remind me right after class today. But I do want to try to get just a little bit more done.
Yeah, and do we have a lecture exam coming up? Because I was confused.
We will after the blood vessels.
Okay, that's good.
Okay.
More time to study.
So is it due today or?
No, it won't be due today. It'll be due in a week to 2 weeks.
Okay.
2 weeks.
Thanks.
All right, so we left off on slide 78. Yeah. Okay, so this question, when, I'll stop that. When the aortic semilunar valve closes and blood bounces off it, it produces the what sound that is ultimately related to when the what happens. So when the aortic semilunar valve closes and blood bounces off of it, it produces the what sound that is ultimately related to what? You guys, what causes the aortic semilunar valves to close?
Contraction.
Contraction, are you sure?
I mean, that's my initial thought. Like, it just came out of my mouth. Like, I'm thinking out loud and I was like, contraction, but it's probably it's them probably opening. I want to say opening.
Wait, are you sure they're opening? Where are they close? Look right here. Where are they closing? Where are the semilunar valves closing? When do they close?
After the AV valves close, then they open, then they close, and it goes back and forth.
Right. So the blood is gonna, when the ventricles, when the pressure in the ventricles finally exceeds that in the, finally exceeds that in the aorta and the pulmonary trunk, the blood is gonna move out through that valve.
Okay, I got it.
Yeah, when the pressure finally, and then the pressure is going to drop in the ventricles because they're going to relax. And then the pressure is going to be less in the ventricles than it is in the pulmonary trunk and the aorta. And the result is that the blood is going to try to flow back and fill up those valves and close them. Does that make sense?
Yeah, I was not thinking it. I was going from my head, like just at first I needed to talk it through. You know what I mean?
Right. No, I understand. So what's the answer?
B. Wait. D as in dog.
D as in dog,
yeah,
right.
Dog, I agree.
Okay. So during when the valves are opening during the cardiac cycle, the valves are going to open passively because of the pressure gradients. And the AV valves are going to open when the pressure in the atria exceeds that in the ventricles. The semilunar valves are going to open when the pressure in the ventricles exceeds that of the arteries.
Okay.
These are really, they're just, it's just when the pressure is exceeded in the area that the valve leads into, they're going to close. Oh no, the opposite. Mary, really? AV valves are going to open so that the blood can flow into the ventricles when the pressure in the atria exceeds that of the ventricles. The semilunar valves are going to open when the pressure in the ventricles exceeds that of the arteries. So the cardiac cycle refers to all of the events associated with blood flow through the heart. We have atrial contraction. So here, remember the ECG. Atrial contraction. Here we start right here. Doesn't really help. Blood is filling the ventricles. The ventricles, the atria then contract. This is atrial systole. Then we have what's called an isovolumetric contraction, or also isovolumic contraction. And then the pressure in the ventricles is going to exceed that in the arteries and open up the semilunar valves. Bear with me here. We're going to come to another page. So isovolumetric relaxation. The ventricles relax and they get kind of, and so they relax. And the result is that the pressure in the ventricles decreases. And at that moment, the atrioventricular and the semilunar valves are both closed. This is during diastole. And when there's no blood entering or exiting the ventricle, that's why it's isovolumetric. There's no volume change of blood in the ventricles. Then the AV valves, go ahead.
No, good.
The AV valves open. And the result is that the ventricles start to fill. There's no atrial or ventricular contraction at this point. It's just that the ventricles fill because it's a liquid and it's flowing by gravity. So lower pressure in the ventricles, so it's flowing down. Then there's an isovolumetric contraction, meaning that the volume within the ventricles stays the same, but the ventricles are going to start to contract. The blood volume stays the same as the ventricles contract. And the result is that the valves, the semilunar valves and the atrioventricular valves both close again. And there's no blood entering or exiting the ventricles. Then the pressure in the ventricles exceeds that of the arteries, and the semilunar valves open, allowing the ventricles to eject the blood. So during the isoventricular contraction, isoventricular meaning there's no blood moving in or out of the ventricles. So the AV valves are closed, the aortic semilunar valves are closed. Then, as the ventricles continue to contract, the pressure inside the ventricles is going to exceed that of the arteries. And the semilunar valves are going to open while the AV valves stay closed. And once the blood has been ejected into the arteries, stay with me for just one more minute here. When the blood is, blood is now in the arteries, the pressure is going to become less in the ventricles than what it is in the arteries, and the blood is going to try to move back. It's going to try to flow back where there's a lower pressure in the ventricles and fill up the semilunar valves and close them. At this point, the pressure becomes lower in the ventricles than it is in the atria. And the blood moves and the AV valves open, allowing blood to move into the ventricles again. And then the atria contract. That, you guys, that is the cardiac cycle.
Ooh, that's a lot.
No, it's not.
I think it seems like a lot at once, but
it is. Think of it. Do me a favor. Think of it. Spend some time thinking of this as just being a fluid moving.
And I think that's what you have to do. Like, just because it's blood doesn't make it any different than, like, if, like you've said before, if you run your hose through it, it's going to follow that cycle. Right. It just seems overwhelming. It seems overwhelming because it's blood.
Right. And because it's the heart.
Yeah.
But it's just the fluid moving through a like X-shaped structure.
Yeah.
I have a question regarding the lab exercise. Are they going to only be 3 guesses now, like moving on forward?
Are they really only 3 guesses?
I think this week is. I'll double check, but to my extent of knowledge. It's just, I guess some of them are hard because they're all like fill in blank.